Hi, everyone. Welcome to COVID-19 Right Now from the Yale School of Public Health. I'm James Hamblin. I'm a lecturer in health policy. And we are doing part 2 today of talking about how COVID-19 is affecting humanitarian responses. And I am fortunate to be joined today by Unni Karunakara. He's an assistant clinical professor at the School of Public Health. And he was international president of Doctors Without Borders from 2010 to 2013. He has been a humanitarian worker and public health professional for more than 2 decades. His work has spanned the globe. I could go on and on, but I'll let him tell you a little bit more about background and how that is informing work with COVID today. Dr. Karunakara, thank you so much for joining us today.
Thank you for having me.
There's a lot to talk about today, and if anyone has questions or comments, we'll do our best to address them. If you're watching live, drop them in the comments, and we'll get to them by the end. But I was hoping you could start just by telling us a little bit more about some of the international work that you've done in the past, so we can have some perspective on what is, informing how you're thinking about the pandemic today.
So I'm a medical doctor. I trained in India, and I came to New Haven in 1993 to study public health. And it was while in New Haven at the School of Public Health that I joined Doctors Without Borders. And so even before graduation, I was already in Ethiopia by then. So I wasn't in New Haven for my graduation because I left early to go to Ethiopia. And that's how it started. And since then, I've been in many countries, many places around the world. Now, in addition to traditional public health work, where you provide care for, mental and child health, health systems work, healthcare delivery, etc., etc. I've also done quite some work in neglected disease. So I've quite some experience with sleeping sickness. But the other big disease sort of area that I have some experiences in epidemic or outbreak response. So I have responded to a couple of Ebola outbreaks in Africa. So this was in early 2000. So in the Republic of Congo, not DRC, but the other Congo, and then of course in Angola and Uganda and other places. So a lot of the perspectives that I have on pandemic response is informed by my work on Ebola and other sort of cholera, etc., that I've had over the years.
Okay. And what has been the focus of your work with regard to COVID-19?
So COVID-19, of course, I've recently received a grant from the Open Society Foundation to not look at the medical aspects of the pandemic, but to look at how the pandemic has sort of the social cost of the pandemic response: access to rights, protections, healthcare for the most vulnerable, the marginalized people. And then we are particularly interested in populations and groups that are displaced, detained. In India, daily wage workers are going through incredible problems as a direct result of response policies. Migrant laborers. Then, the people have been profiled in New York City. There have been examples of Asian-looking people being profiled and attacked. Then stigmatization on the basis of race, ethnicity, gender, sexuality, religion. So these are the kind of things that we are looking at. And this grant is through the Yale Global Health Justice Partnership, which is sort of a collaboration between the School of Public Health and the Yale Law School. So we're just getting started, and there will be a steady stream of perspectives, commentaries coming out over the next year. And the objective is to influence policy in real time, because we're in that situation where policy is being built. It's like building an airplane while flying. That's what we are doing with this pandemic. There's so much that's not known, not just about the disease itself, but also on how best to respond to it. So rather than wait for a 1-2 year peer review process and then publish papers, what we want to do is to sort of bring perspectives to the public domain as quick as possible, so that that is then taken into account by policymakers and government officials, etc.
Yeah, the whole publication process is being so sped up academically and in many other ways during this pandemic. I am interested to see how that carries out in the future. You mentioned some of the effects of reactions to the virus. It seems like every policy that's put in place, every decision that's made with regard to this pandemic also has downstream effects and negative side effects, whether it's sort of discrimination or creating inequalities or things that probably were not intended, hopefully were not intended, but require the eye of someone who can foresee how this will have negative consequences down the road. I'm wondering if there are any examples of how your humanitarian work has helped you to identify what we should and shouldn't be doing in this moment.
So before I go into humanitarian, I mean, writers like Yuval Noah Harari have written about the sort of the intrusive nature of technology, the use of technology in whether it is to test and trace and help quarantine people. Some of it is absolutely necessary, but there has been, some states have used this opportunity to bring military grade technology, which he feels that will not be easily rolled back even after the pandemic is over. So his concern, and he talks about, really interesting article, he talks about that we seem to have gone from over the skin technology to under the skin monitoring technology. So, and in very intrusive ways. So we will not know the full effect of all of the policies that have been, and a lot of it with very little public discussion and oversight. These policies have been adopted, and we won't know the full extent of what we've gotten into till much later. Now, humanitarian assistance is very important because the idealist in me, the humanitarian, would have expected that the pandemic, because it affects everybody, is a point in time in history where everybody will come together to address it as a shared vulnerability, a problem that affects the entire globe. But that hasn't been the case, right? So we see that global governance has been challenged, especially at a time, WHO, World Health Organization. Of course, it's not a perfect organization, but if there is any moment in history when you need an organization like the World Health Organization, it is now. So we have seen that the organization has been undermined in many ways. All of this is not boding well for how we will come out of a pandemic, out of this pandemic together. Yeah, just yesterday I read that the US has cornered the stock on remdesivir, the new Gilead drug that is $10 to make, but they will be charging $3,000 per treatment, and US has cornered the market. So even for future treatments, potential vaccines, there will be a competition, which is you're competing in a marketplace where a lot of the countries where we work in, the poorer countries, will be left out, right? Because they are not able to compete with the big countries. Now, one of the biggest, so you all remember the 2014 Ebola outbreak. So in 2014 Ebola outbreak, 3 countries in West Africa and then around West Africa, these were some of the poorest countries, and it was no surprise to any of us that the health systems didn't function. They didn't have the capacity to deal with an outbreak like Ebola. But what we are seeing in this COVID-19 pandemic is that almost all of the rich country health systems have also dysfunctioned. So so they have all the money they need, but some missing X factor they don't have, or they're not able to mount effective pandemic responses. So this is actually calls to question a lot of the expertise of rich countries to advise poorer countries on how best to structure their pandemic response. So that is one thing that we are contending with at the moment on uh, what advice to give, and forget the human resources. I will get into that maybe a bit later.
Could you say a little bit more, though, about the idea? I mean, I think to a lot of Americans who believed that our healthcare system was the best in the world, and that our that we were somehow exceptional in all kinds of ways, are surprised to see the numbers being so bad. And we're not the only wealthy country that has fared poorly. Why isn't there a stronger correlation between the wealth of a country and the strength of their response?
Yeah. So, I mean, the US is a very strange case because, people come from all over the world to study public health in the US, because the schools of public health in the US, they understand that health is not just a individual construct. It is a social, economic, political, environmental construct. All of these different factors play a big role in health outcomes, right? But somehow, when it comes to the health, infrastructure, the health policies, and the way healthcare is provided, all of this somehow does not sort of come into the picture. So you have care that is highly individualistic. So if I have a rare form of cancer, I will come to the US for treatment, because they will somehow figure out what to do, and they'll get it done. But that does not make a health system. Health system has to, and the public responsibility is that health is for everybody, not just for the few people who can afford it, right? And I think that is where the logical error of the American health system is, that they think that just because they can provide expensive care for rare diseases, that will then reach everybody. And what you were seeing in this COVID-19 pandemic is also that a lot of the good examples of response have come from not so rich countries. Vietnam, for example, they have zero deaths. Korea, where I live, has had their first case of COVID-19 on the same day as the United States, and they have a 60 million population, and they've had 282 deaths.
Wow.
Right? So, and then you have Kerala, the state where my parents come from in India. It's a poor socialist state with not much resources. They have a population of 30 million, and they've had 7 deaths.
Wow.
Right? So that is when you start thinking about, what does it take to provide care to everybody? Health system for all, or healthcare for all, does not have to be very expensive.
Right.
Even among OECD countries, the per capita return in health spending in terms of health outcomes is the worst for the US. So there's something, and there are a lot of things that are not going right in the US. So anyway, so we can go back to humanitarian situation.
No, I mean, I think that's very relevant to the moment. At the same time, I think a lot of people are feeling that there's not the political momentum right now to actually do anything in a systemic level right now, apart from before maybe a November election, but I would like to contribute, to the cause somehow, that there are ways that maybe, things that people in the global public health community could be doing to come together to help the response that could be
So
informed by some. Yeah.
James, you can adopt 2 strategies. One is a suppression strategy, that you come in early, you sort of completely suppress the epidemic, you stop the transmission from person to person, community transmission, and you suppress and you contain the epidemic. This is what Korea has done, New Zealand has done. So they've actually, so now it doesn't mean they don't have cases, but it comes in dribs and dabs. They have like, 2 cases or 20 cases, but the system is able to immediately come and contain it and prevent community spread. Or you have a more of a mitigation strategy. And mitigation strategies usually are, massive countries like India, and the US to some extent, and partly because they didn't act early enough. So they didn't act early enough. Their preparedness was not good enough. They didn't have all of the tools that they needed to test everybody, identify contacts, trace, etc. Right?
Mm-hmm.
So a lot of the US is in a mitigation strategy. What they're trying to do is keep the number of cases at a manageable level. They're not even thinking of stopping community spread anymore. They're trying to keep it manageable so that the number of the intensive care capacity matches the cases that come in. So a lot of countries are in mitigation mode. So when you look at the poorer countries, the kind of resources you need to bring to bear to put suppression strategies in place you can forget it. So you have to look at mitigation strategies. But even with mitigation strategies, there's no one size fits all, right? So even though you can have global recommendations that come from the World Health Organization, the implementation of mitigation strategies have to necessarily be local. It has to take into account local sort of specificities in how you implement it. Because it has huge economic costs. In majority, big part, in most of the world, if people don't work one day, then they don't eat that day. So it's a different sort of challenge that we face in a lot of these countries.
Right. Okay. Well, so there are places that have been able to suppress the virus despite not having a lot of money, but these are not the poorest countries. Yeah. This is somewhere in the realm of not being as wealthy as the US, but wealthy enough to be able to suppress the virus. Is that right?
Yeah. So the 3 most important ingredients are test. So testing very early on and free. It is available for everybody. Anybody can go and get a test. Because what that does is you are immediately able to identify contacts, and then you can follow them up and sort of, and in all of these countries, what they've also been able to do is, because they identify cases early, they're also able to prevent cases from getting serious, so that they end up in critical care. So they're able to prevent that. And so but one important ingredient in all of these places is transparency. China is perhaps not a good example, but in almost all of the other countries, there has been open and frank presentation of facts, challenges that the government is facing, and a complete buy-in from the population on the need for certain strategies which might limit freedoms for a certain period of time. But in most of these countries, people have willingly sort of complied with directives that have come. And that comes with transparency and trust that you build with the authorities. And in a state like Kerala, where I come from, you also flip things around a little bit and put some of the onus of response on the people themselves. So you treat people like adults. So for example, Kerala does not have the capacity to provide quarantine and isolation for all of the high-risk groups, like elderly, chronic diseases, et cetera, et cetera. So what they did was they put the families in charge of protecting the most vulnerable in their families. And they made it possible for them to do that, including delivering food home, giving them extra supplies and extra financial support during the period that they all need to stay at home together. So instead of putting institutions in charge, they put the people in charge. again, there has to be a certain amount of trust. And if you look at what's happening in the US, the discourse in the US and discourse in the UK, that is a big, big missing ingredient. That there is no trust in the directives that come from the leaders, the political leaders of the country. So that makes it less likely for people to comply with directives that come from the top.
Right. Um, I'm just curious, and it seems like such a moment of stagnation and purposefully sowing distrust in whatever person politically is not on your side in the U.S. and I guess a few other places. Are there lessons in how we could rebuild that trust, or is that a function of our system that there are always going to be people who are trying to get you to not trust the other side?
Yeah, I mean, it's a function of the system, but also a function of where we are. I think there are a lot of things failing at the same time. Our political systems are failing globally. Democracies don't always elect the best governments, and that is true in many countries around the world. The politics is failing. There is a crisis, climate change, environment. We are reached at that heating, a crisis moment. There is conflict. So there are many things that are coming together to create an atmosphere of mistrust, not just between individuals and their governments, but also between governments. Right. I don't know how we can solve it overnight, but it is. But if you look at someone like Tony Fauci, the amount of time he has to spend combating misinformation, right? Just the sheer amount of time and energy you need to combat misinformation. If you could spend all that time sort of focusing on facts and engaging with people on what needs to be done and what should not be done, we would be much farther ahead. So that has been zapping our energy from resource efforts as well, this misinformation and sometimes deliberate misinformation that comes our way. So it's difficult. And so also to put it in historical perspective, if you read about historical pandemics, this is not that unique, right? In the past, almost all plagues, pandemics, etc., they all have, rumor mills, stigma, misinformation, all of that. But I would have thought that given the nature of information technology, we are talking about 100 years after the Spanish flu, we've come a long way in how our ability to communicate to each other, our ability to transmit facts to each other, but somehow we seem not to have learned how to do that well in the last 100 years.
Right. So maybe it's a human problem and not so much a technology problem.
Yeah, I think we are all very fearful. And of course, add to that, Black Lives Matter. All of these are so many very critical issues that go to the very foundations of our society coming together at the same time. And people are very fearful. So yeah. From a human level, I can understand there's only so much information we can all absorb at one time.
Yeah. One of the reassuring things that people have told me, and it's been empowering, is this, the old motto, think globally, act locally. You've said that there are local responses that can work. There are always things that even if you can't personally improve the entire information landscape, there's at least one person you could talk to who will listen to you and could have their mind changed. And I'm wondering how you square practical advice like that with your work as being international president of Doctors Without Borders, of thinking globally about these problems and staying effective in scoping your work appropriately.
So, I mean, one thing I do is I try to triangulate information. So I sort of almost expect all information to have some inherent bias in it, including peer-reviewed articles, because there's a lot of evidence that that peer-reviewed articles are also not free of bias. So triangulation, I think, is important, but even triangulation can only get you so far. Right? Now, as a massive or a large medical humanitarian organization like Doctors Without Borders, when it looks at how do we even get started in supporting um poor health systems to better withstand something like a COVID-19 pandemic, even we are, even in spite of all of our experience with Ebola outbreaks, etc., this is a completely different ballgame. So imagine this. I remember 20 years ago going to Congo in a very remote village. So what we did was the people who were tested positive for Ebola, we would bring them into a school or a facility, and we will then isolate them. And the whole objective was to stop them from infecting others in the community. So you are preventing new chains of transmission outwards. But in COVID 19, given the scale, I mean, how fast this is spreading, we have to turn it around in its head. We have to assume that almost everybody is infected. And the strategy here is how do we prevent the most high risk from getting the infection? So,
Right.
in some ways, you might want to isolate people to prevent them from getting infected in the first place, because the elderly and the high risk groups, if they get infected, then mortality rates are likely to be very high. So
Right.
that's one challenge. The other challenge is we all know that the first people to get hit anywhere in the world are health workers, doctors, nurses, community health workers, etc. How do you protect them, right? Whether it is with PPE, whether it is with a vaccine in the future, even this has been problematic because it hasn't been easy to secure supplies
Right.
because there is such global competition for supplies, securing supplies and then also transporting supplies. Now, one silver lining on the is that as global governance dysfunctions, we are seeing some optimistic signs of regional governance sort of working. So regional groupings like the African Union and other small groupings are coming together to sort of coordinate response plans, coordinate supplies, etc. So that for me is actually a good thing to come out of this, that people are figuring out how to solve their own problems. That does not absolve us and rest of the world from not showing any solidarity and not showing any support, whether they need monetary resources or other kind of resources. So that is something that we as a global, as a community of nations, we have to think about it.
Right.
How do we support each other? And a lot of countries are now thinking about supply chain sovereignty, that they cannot, in times of crisis, they cannot rely on a global system to meet their needs. So they have to prepare for the worst, either within the country, that means they have to have pharmaceutical manufacturing capacity in country for basic medications, life-saving medications, or at least regionally. And similarly with materials that they will need to protect themselves, etc. So
Yep.
all of these conversations are happening at the moment, and we will see how it'll all play out in the coming weeks and months.
Right. Right. Well, I have lots more questions I'd like to ask, but we are unfortunately short on time. I did want to ask you if there's anything that I hadn't gotten to ask about or that's really pressing or that you wanted to come back to for any final comments. That there could be a moment to do that. Is there anything like that?
Yeah. No, I mean, I would like to stress on the need for like global governance, and global governance, not just, it is how to ensure that no one is left out, that people who need the tools to not get infected or to get better should be able to have access to it. And that too, not like remdesivir. If it is $3,000 a treatment, you can forget it. You can
Right.
imagine. And this is a drug that doesn't even work all
Doesn't
that
even
well.
help. Yeah.
Yeah. So, and this is also a fight that as Americans you have to do it. First, you stockpiled hydroxychloroquine. They bought up all of the stocks of hydroxychloroquine. I think $30 million worth from India, and now you're stockpiling remdesivir, right? And all of this based on, first of all, remdesivir. A lot of the development happened with public money, right? And they're turning around and they're monetizing on it in a big way. So I think I spent many, many years fighting for access to healthcare for poor countries, but the same challenges exist in rich countries as well. I think people are not able to access healthcare in an affordable way in rich countries as well. That's another dysfunction that people in rich countries have to deal with as well.
Yeah. Thank you so much for your insights. Thank you for your work. I hope that the work with the grant goes well for you. And thank you all to everyone who has watched. We are going to be taking a summer break from these broadcasts, but we will talk to you again soon enough. Thanks so much.